hormone. And we all know our test taking strategy, right? We're going to start with the posterior, memorize those two, everything else falls in the anterior. So if you know the posterior, you're good to go, okay? I'm not going to put an answer on the test that it's not one of the hormones secreted from the pituitary gland, okay? Where I put like, I don't even know, insulin or something like that, right? It's going to be the actual hormones from that pituitary gland. So going through your hormones, you want to understand what they do. So a lot of this test is just back to pathophys. I promise you, I would say the endocrine portion of it, half the questions at least are just, what is the pathophys of these hormones? What do they do? How do they work? What is too little or too small, or little or more need for that patient? So if you have the pathophys, okay, it's going to help you a lot with this test, okay? So with the posterior pituitary gland, antidiuretic hormone is probably one of the most common hormones we've talked about this semester. And it's one hormone that I really want you to take with you to your boards. Now, oxytocin, you might not get anything on your boards with oxytocin. Or even like luteinizing hormone, FSH, you might get zero, none. You will for sure get an antidiuretic hormone question on your test. Whether it's with blood pressure, your renin, angiotensin, aldosterone system, having someone with SIDH, like there's gonna be something with antidiuretic hormone. So I want you to think about, because this is how I have to think about it. You can memorize the table of SIADH and diabetes insipidus all you want, but you have to think about what does antidiuretic hormone do, and that will help you. So let's think. Diuresing, what does that mean? Urinating or getting rid of fluid. If I'm anti-diuresing, I'm stopping diuresing. So it's a hormone that stops diuresis, okay? So if I have too much of that hormone, and you might have to talk yourself through it through the test like this. If I have too much of that hormone, I'm going to retain a bunch of fluid, okay? So a person that has SIADH retains or makes too much of that antidiuretic hormone, which is gonna cause fluid retention. So if all the fluid is in my body, where is it not? It's not coming out, right? It's not coming out of like your kidneys or into your urine. So if you have low urine outtake or output from someone that has dialysis to someone that has fluid volume excess that they retain it, what does the urine look like? It's dark, it's not a lot, the urine specific gravity is going to be high, right? It's going to be very increased. And so what is the goal here? We always want to treat the cause. So what is one of your common causes of too much or too little antidiuretic hormone secretion? A tumor, right? So we've got to rule that out. Another thing could be like infection, or they lost blood to that pituitary gland. Fix the cause. In the meantime, we can do some treatments like giving them diuretics or helping them get rid of that fluid. Okay, too little antidiuretic hormone. So let's talk through it again. Antidiuresis means that we retain. If I don't make that hormone, I'm going to dump everything out. So if I'm dumping everything out, like in diabetes insipidus, you're peeing like 10 to 20 liters a day. And those are things where if you are getting rid of all that fluid, you're gonna get dehydrated. Those are things where I like to bring drinking alcohol, because when you drink alcohol, you pee, right? And you're like, my urine looks great. We've all looked at it, right? Your urine looks good when you're drinking. What happens next morning? It's dark and concentrated because you actually secrete less antidiuretic hormone when you drink alcohol. So you have this pale urine that looks good, but then as the day goes on, you pee so much, you become dehydrated, and that's why they have the urine that looks worse later. The problem with diabetes insipidus, it just never stops. It just keeps coming out and out and out. So what does specific gravity look like for diabetes insipidus? It's gonna be low. It's gonna look more like water, or that pale color. And the person essentially is dehydrated. They need extra fluids. If you're struggling with just which one produces little or a lot, I always encourage you to look at diabetes mellitus and diabetes insipidus. Okay, very similar words, totally different things, but what do the symptoms have in common? Polyuria, polydipsia. So if you're struggling with the concept of, well, which one's a lot and which one's a little? The diabetes insipidus, they are diuresing too much, kind of like when you diurese too much in diabetes mellitus. So that'll kind of help you with the symptoms. Okay? What if on the test I bring up diabetes mellitus and a patient goes, you get a diagnosis for the first time of diabetes insipidus, and the mom goes, oh, we're going to have to be on insulin for the rest of our life. Why is that wrong? It's a totally different diabetes. We have to make sure the patient understands. See how it could be very confusing for a patient's family? especially like a child that doesn't know. If they hear diabetes, they could think of diabetes mellitus. It could be diabetes insipidus, which is totally different. Okay? All right, just briefly on oxytocin. What am I going to ask on it? I told you what I'm going to ask. What am I going to ask? It expresses breast milk and helps with uterine contraction before and after delivery. That's really it. There are other functionings of oxytocin. I'm aware of, like, you exercise, you release oxytocin, but for the main part of physiology, we're going to focus on that. Okay? Now we are going to talk about TSH, because that's going to be your anterior pituitary gland. So now that's why we're talking about thyroid. So we talked about hypothyroid first, and I just like to make my table because it helps me go back and forth. But I told you a test question that's going to be on the test, and it had to do, it had to do with the hormones, because there's going to be different hormones on this test that you'll have to identify, are they high or are they low? So when it comes to the king or the queen of the body, TSH stands for thyroid stimulating hormone. It is secreted from your anterior pituitary gland. This talks to your thyroid gland. So constantly there's this negative feedback system that if your thyroid excessively secretes too much hormone, the thyroid stimulating hormone says, slow down, no, 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 and it tries to lower. And vice versa. If thyroid stimulating or thyroid hormone is low, it's going to say, I need to kick it up a notch. The pituitary gland says, let's speed it up, let's go more. Okay? It's a teeter-totter. It never wants to be high and high or low and low. We don't talk about what that causes because I'm not going to ask you on the test. You just have to know a foundation of high and low. So with hypothyroid, there are T3 and our T4. Where does this thyroid hormone come from? Does it come from the pituitary gland or the thyroid? This is the thyroid, so this is coming straight from your thyroid gland. These two hormones do not get secreted from your pituitary gland. TSH does. Okay? So what will T3 and T4 be for hypothyroid? Low. Hypo is low. What will our TSH levels be in this case? High. So they're opposite. Okay? So hypothyroidism, I think of everything kind of slows down. When you're on the test and you're looking at side effect or symptoms, and you're like, what are the symptoms? Think of everything low. Everything's lethargic and slow and bradycardic. Everything kind of slows down. So constipation, even your bowels slow down. Your heart rate slows down. Your energy slows down. The only thing that doesn't slow down is your weight, right? But you could argue and say, well, your metabolism slowed down, so your weight was gained. So a lot of times people come into the clinic with these symptoms, and if you had a patient that was constipated with low energy, that was just kind of tired all the time, you should think thyroid. However, could it be another 20 other things? Yes, absolutely it could. But these are things that doctors will rule out and say, let's check your thyroid, just to make sure everything's doing okay there. And what they're looking for are these three hormones. This is what they'll take. Okay? What is the medication of choice? So I believe on your test, I just have one med on hypothyroid, and this is it. So levothyroxine. There is only one other med that I've ever seen for thyroid, and it was called Armour Thyroid. I think one of you had to give it on the floor this semester. I had to ask the nurse practitioner what it was, because I've never heard of it. It is pig thyroid, like artificial pig hormone from their thyroid that they give. Why did they choose that instead of levothyroxine? There was a problem with the levothyroxine. Yeah, they're allergic to it. So think about the people that are allergic to levothyroxine, Synthroid. There has to be another option because you have to get thyroid hormone. So they got it synthetically from a pig and gave it to the person. Ironically enough, we get pig insulin all the time. That is a thing. We get insulin from pigs a lot. And remember my pig transplant? I mean, pigs are kind of very, very commonly used. So levothyroxine, these are the questions on your test that you're going to want to be familiar with. So knowing that it's not an instant fix, it's going to take some time for it to start working. Yes, there can be times where it starts working as little as 2 weeks, but you have to say 6 to 8 weeks for this reason. If you tell them 2 weeks and they are not feeling good by 2 weeks, they're going to say, I'm mad at you. You told me 2 weeks, right? In some people, it can be earlier. For the most part, it's later. 4, 6, somewhere in that time frame of weeks. When they're in the hospital and they have this problem, what is it? Exedema coma. okay? So they're either not taking it or their body's not absorbing it some fashion or form. So maybe they got their thyroid taken out from a thyroidectomy and they're not replacing it with their medications. So is this a cause to be hospitalized? Yes. If you see this on the test, this is the most severe form of hypothyroidism. They will be hospitalized. So let's say they haven't taken their meds or they've taken it inconsistently for a few weeks. We can't just say, let's take your oral pill and in 6 to 8 weeks we'll see how you're doing. You have to get something faster. So what would be a better option for this issue? IV, okay? So ironically enough, on this test, you need to look at the route, especially when it comes to what is the goal for this patient. If the patient's goal is to just, hey, we got you a diagnosis of hypothyroid, we're gonna start you on this oral pill, we'll see you back in 6 to 8 weeks. It's their initial, they're not too sick, they're not hospitalized, nothing, oral is completely fine and preferred. But if they're in a mixed edema coma, how would you know they're in a mixed edema coma versus just someone that has hypothyroidism diagnosed for the first time? Probably right here. Sorry for the orange you can't see. Lethargy to the point where they're unresponsive, right? Because coma, everyone knows what a coma is. They can still be awake during this, but they're so lethargic and so bradycardic that they're gonna start to have secondary issues, like cardiac arrest, if they do not get this fixed. So you're looking for a person that has mixed edema coma, hypothyroidism, but they're having horrible symptoms. And they're in the hospital, that's a good sign to probably say, let's do some IV, okay? And then this person will always have their oral pill in the morning. IV doesn't matter as much. Why? Why does IV not have to be on an empty stomach? You're bypassing the stomach. You don't need to have IV, and this is not on your test, but I just want you to know for future reference, you don't have to be on an empty stomach for IV medications, okay? The only time you'd ever say you should eat something is like morphine, because you feel sick from the side effects, not because of absorption, nothing like that. Okay, so this person will have oral medications hopefully in the morning on an empty stomach. What are some good medications that usually are the culprits for not absorbing medications? So ones that are for every med. You don't want to take meds at the same time as these types of meds. Antacids, iron. Iron is going to bind to a lot of these medications. Antacids is going to neutralize the stomach. So like your proton pump inhibitors, like omeprazole, Tums, ranitidine. Oh, I'm finding a marker. Thank you. Where'd you find that?
What's her name over here?
Oh. You're like, the orange is causing your brain to hurt. And then making sure that you just have no food in the morning. So that'll be a big thing to remember for that part of the morning. Okay? So levothyroxine, what is, and it tells you right there, but why do we give levothyroxine? What is it mocking, or was it a synthetic form of? T4, okay? So I mentioned that levothyroxine is what we typically give for hypothyroidism. You could technically give another medication, and it is T3, it's just not very commonly given, but we could potentially give it to people that need it, if that is their low part too. So levothyroxine is going to be converted to T3 in the body, so it does the job pretty well for both. Okay? So here's our mixed edema coma, very life-threatening. Why would someone go into this state? It's typically not taking their meds. However, if they get severely infectious, they have trauma to their head, really anything else could cause this as well. But we want to make sure that we rule it out and treat the cause. Notice too, this one right here, leothyronine, which is also called Cytomel. This is T3. It is out there. Is it common to give? No. But I do want you to be aware that T3 can be given through the IV as well as through oral if the person is in a state where they are severely hospitalized with mixed edema coma. So they might even potentially be giving them IV levothyroxine and IV Cytomel, where they give both because they're such a severe state. So it is possible to give both of them. So you're looking for these components on your test. Person comes in with what? Lethargy, bradycardia, cold intolerance. What does cold intolerance mean? I am not cold intolerant. I'm a hot-blooded person. You know the people that are always cold, they always have a blanket on, always have a sweatshirt on? Those people. What is that usually from? Yes, adipose tissue, but circulation, right? Theirs is more circulation issues. Not because they're fat or skinny. It has nothing to do with adipose tissue. It's because their circulation is poor, and it's not giving warm blood to the rest of their body. Okay, Any questions on hypothyroidism? I would know this slide very well. You have to know these symptoms. Because I'm going to give you questions that say, what are the symptoms? Or in the stem of the question, I'll give you these symptoms. So make sure you know what these are or how to treat them. Even as far as to like, if they have constipation, they still will have constipation even when they take their meds, it just won't be as severe. You might have to encourage ways to prevent that. Or dry skin, you might have to avoid hot baths and take lotion and make sure that they're moisturizing their skin. Wear blankets, those kind of things. Okay, so here comes hyperthyroid. We're going to kind of start with the same stuff we did on this side and near it, because it is the opposite. So hyperthyroidism, you're going to have what to your T3 and T4? High, and your TSH will be low, okay? And I always think of hyperthyroidism as people that are hyper. I've always thought, because I've known a couple people with hyperthyroidism, and they are textbook people. They're the same person. They're usually thin in appearance because everything speeds up. They're thin, they have a lot of energy, probably to the point where it's unhealthy energy, like they're just like constantly tapping their feet, clicking their pens, they're moving around, okay? And they tend to lose weight because of that. They have high calorie diets because they're hungry all the time, but they don't gain weight, okay? No gaining weight. And they might even lose weight, okay? What do you think their heart rate and blood pressure would be? If everything's hyperstimulated. Be high, yeah. So one of the biggest concerns we have with hyperthyroidism is they get to a state where they go into like a thyroid storm. I would say myxedema coma is the exact opposite of a thyroid storm or a thyroid crisis where they are hospitalized. A thyroid storm is just that. When a storm comes, it means kind of like it rains, it pours, and it's going to be very hard to manage at home. They will have to be hospitalized. What is one thing we're very concerned with a thyroid storm? If it gets really bad, they could have a stroke or a heart attack or some type of heart issue because their blood pressure is so high or their heart rate becomes so high. Okay? Do you remember what they look like? I brought this up in patho. They have a very obvious appearance, and whenever I see this, I go, I bet they have hyperthyroidism. Okay. They have the bulging eyes, okay? So in patho, I just told you what is it, because I wanted you to know what it was called. Exophthalmos. Oops, spelling. Okay, exophthalmos is the bulging eyes, okay? And in 1 year's time, this is how fast medications and time changes, there was no treatment last year. They just came out with the treatment this year for exophthalmos. Because I told you in patho that if you have hyperthyroidism, even if you get treated, your eyes never go back down. They might come back a little, but they're still kind of bulging, even on treatment. They just came out with the treatment to help this problem. Isn't that cool? Like even just in 1 year of nursing school, a new med came out to fix something. That's how fast technology changes. So, now don't ask me what it is because I don't know, but there's a medication out there because I've been obviously doing some clinical with a guy that treats this occasionally. He's like, they just came out with it. What's the problem here though? It's gonna cost a lot, right? So it takes about 7 years for a medication to become generic. So are people gonna wanna pay for this? Yes, because they don't wanna look the way they do, right? And it causes complications. What do you think would be one of the top things that is, I don't wanna say annoying, but bothersome to a patient that has this issue? What do you think is the one thing that they say, I want this gone because of this reason? Say it again, Cindy.
Do people look at them?
Yeah, it's a body image thing, right? They have impaired body image. How many times this semester on a care plan did you use impaired body image or altered body image? Not very much. I think there was one of you that did it for a new colostomy bag. It was the Hutterite guy. Who was that? He was the new Hutterite and he was like, I don't know, look at him. He had altered body image. Now he's gonna have to live with this bag on him and he had to learn how to live with this new image. Burn victims, huge altered body image. If you have a burn victim to the face, or even to the exterior of your arm or legs, and you have to wear shorts or have your face be shown, they're gonna be mortified. So you have to consider that these people walk around, you can't hide your eyes, right? I mean, if you wear sunglasses, but you can't do that all the time. But these people have these body image issues, and if you have a patient that has this issue, Could they be at high risk for mental health issues or suicide or things where they don't even want to be seen? What if it's so bad that they can't meet somebody to be with and they get upset because they have no one to share their life with? This is very real and could happen. So let's think more about not the mental aspect side of it, not the body image side of it, but let's think more about the physiological problems that can happen with it. So what we are concerned about in the hospital. So if your eyes were open like this all day, you can't blink when you want to blink, or when you blink it goes down to here, but you don't actually close your eye, what would your eyes feel like? Dry, right? The reason we blink is because it gets dry and it has to be kind of moisturized again. So they have very dry eyes, so we give artificial tears to these people. Artificial tears is basically like contact solution. You just kind of drop them in the eye, keeps them nice and moisturized so they do not become dry. Dry eyes, I feel like I'm Bill Nye the Science Guy, or whatever that guy is, dry eyes. You have to put this in there or else infection will occur. So when you have pink eye, most of the time pink eye is like a viral infection, even though we run to the doctor to get antibiotics. But you know what will prevent it if there's someone in the house that has pink eye? Keeping your eyes nice and moist. I know people don't like that word, but keeping them nice and wet, because the moisture flushes out the infection. Or when someone has pink eye, you should flush it out a lot with a bunch of saline to flush out the infection. And that is why people with exophthalmos have a high risk for infection. Okay? Another problem with exophthalmos that is up there for our concerns as providers and nurses. Think about it, if your eyes are open, they have a more chance of trauma, right? So this last 6 weeks of wind, all this wind coming and blowing dust in your eyes, it happened to me and I have good eyes. Like, I don't know how people with like exophthalmos would deal with that, where they get dust and they could get like corneal abrasions on their eye from the dust or the gravel coming to their eye. Sun, we've all been there on a sunny day and you're like, oh my God, I can't even look at the sun, it's so bright, right? Now picture your eyes open about 40% more, letting more sun inside of your eyes. Your eyelashes and your eyelids kind of act as like a tent for your irises, so you don't have that sun. But if you look straight at the sun, it's going to come right in there. So having this problem will have issues with sun. So what do we tell them to do? Wear sunglasses, right? So you might have to wear sunglasses or some type of shield if you're going to be in some type of high-risk area, or if it just kind of hurts to be outside for that reason. They have shown that sleeping with an elevation can help, just because of like the pressure behind the eyes. So that if you lay flat all night, they say the eyes are worse in the morning. So they say lay with like some pillows or elevation. And then surgery. What do we do for surgery for these patients? We tape their eyes shut, okay? Because we don't want during surgery someone's eyes just like, hello, awake and looking at us, right? Because we also don't want them to like, we think their anesthesia's not working. So if we see someone's eyes open, we say, oh, anesthesia must be increased, but they're completely out. We do not want to harm them by giving more anesthesia. So they tape their eyelids shut. This also happens a lot with if these people pass away, because when people die, usually their eyes do shut like this, but theirs will not shut. So you have to close their eyes with a piece of tape. It does happen quite a bit. So who is at increased risk for hyperthyroidism? I think of the same thing for hypothyroidism. Middle-aged females. So let's say you have a test question on thyroid risk factors. You're looking for middle-aged female for both. That is kind of nice. They have the same risk factors. So if you have an 85-year-old male, whatever, usually you're not going to get a diagnosis of thyroid issues at that age unless of one thing. They had a thyroidectomy. Took your thyroid out and it caused issues. It's not usually going to happen if it hasn't by then. Okay, people that have thyroid disease typically have some type of autoimmune background. Maybe they had lupus or some type of autoimmune problem that put them at higher risk. Raynaud's disease is another autoimmune. Type 1 diabetes, like anything that's considered autoimmune would put them at higher risk. What medication specifically would put someone at high risk for thyroid storm or hyperthyroidism? Why would that do it? Too much, okay? So let's critically think through this, because we all in here could say, yeah, thyroid hormone can cause excessive thyroid hormone. But how would it look on a patient assessment coming into the hospital? They have a history of hypothyroidism, they're on levothyroxine for their drug, and they're complaining of we have tachycardia, high blood pressure, and heart palpitations, whatever, right? Symptoms of hyperthyroidism. You ask yourself, what would you do as the nurse? Do we say, stop taking your medications? No, you never say that, but you suspect that there's thyroid excess hormone, you should notify a provider, and they would do what they need to do. Okay? We always never tell the patient to stop taking their meds, but we anticipate that this is causing too much thyroid hormone. What would probably happen? They'd stop the dose for a day, lower the dose. Is probably what they would do. Kind of like let it come out of your system for a little bit, and then start it at a lower dose. Graves' disease is an autoimmune problem that causes hyperthyroidism. So on your test, if you see a person comes in with Graves' disease, you would associate that with hyperthyroidism. Okay?
Do you have no clinical manifestations for that, or just no?
It is the same for hyperthyroidism. So like if the person has Graves' disease, they have hyperthyroidism. And Graves' disease is more associated with having this exophilus. Like they have more of the symptoms with this because they have the autoimmune problem that causes it. I mean, I've known people too that have hyperthyroidism and they don't have exophilus. It's not like 100% of people have this, or maybe they don't have tachycardia and high blood pressure because they have minor hyperthyroidism, or they have very well treated hyperthyroid. We are thinking people that take too much or they potentially are not treated and it causes this issue. Okay, they have these major side effects. Okay, so we should go down this list. I know this is a lot, but I want you to stay with me for a second. On the test, I'm going to make it obvious that it's hyperstimulation of your metabolism or increased stimulation of your heart, things that are sped up, okay? So when you have a person that has hypothyroidism, they have constipation, what is the opposite? It's going to speed up your motility. Here comes diarrhea. So what are we not going to do for these people? We're not giving them laxatives and stool softeners and high fiber foods. It's going to make them have more pooping, right? So we want to make sure that we actually are cautious that these symptoms could be debilitating. They can't be pooping 10 times a day. Fluid and electrolyte status. We worry that they might have loss of fluid and loss of those electrolytes. So make sure we replace those if that happens. These are the people in the hospital that you do not want to cluster cares. Why would I not cluster my cares with someone with hyperthyroidism in the room? So let's say they're hospitalized. Getting calls from everybody. The person is hospitalized and they have a thyroid storm where they have very high heart rates, high blood pressure, they're very highly stimulated in the body, central nervous system wise. Why would I not go in with their tray, take their vitals, do their assessment, do physical therapy, and whatever else I need to do with them, do my head to toe assessment for my class I have to get done. Why would I not do all that in 20 minutes time? It's too much stimulation to their body. They need small bouts of, in the matter of 5 to 10 minutes, about the max they should have. They even have people in the hospital with thyroid storms, you're not allowed to turn the light on. I mean, you can have like a little bedside lamp, but too much light is gonna cause too much stimulation. Or their exophilus is so bad that the light is gonna cause issues. Hot, they are sweating. They are super hot people. That's why they're thin, right? They're sweating a lot, their metabolism's high. But a lot of times if we get them a fan or cool rags to the head because they're so sweaty and hot. What does this word mean? I've said it before, might have been a while. Pyrexia. You're a pyromaniac. Fire, right? What does fire mean in the body? Fever. It's a fancy word for fever. So pyrexia, you can actually have people with this excessive stimulation can cause fevers because they get so hot in the blood flow. So they could have some fevers that would require medication. How do we assess a thyroid? From behind, right? From behind while they swallow, and we assess on that part of the lower part of their trachea. Okay. What kind of interventions would the nurse maybe do for this patient other than what we've just said relating to the heart? So I saw in here they have tachycardia, dysrhythmias. Is there anything else that we want for this patient? Think about what we do as just interventions or things that we monitor to make sure they're okay. What do we put on their skin? Here. Telemetry, right? This would be a perfect example of a person that should be on telemetry. Now, a thyroid storm probably would be in an ICU based on their complications. However, if they were on the med-surg floor, they for sure should have telemetry. What is amenorrhea? Because it's the opposite of this. This was heavy bleeding, okay? Amenorrhea, A means none. They don't get a period. So what kind of issues, you guys haven't got to OB class yet, but stay with me, men. Females might know this, but men, stay with me. If you don't have a period, can you get pregnant? No, you cannot get pregnant if you do not have a period. You need a period to become pregnant. Or if a person is irregular, or they don't have a regular cycle, it's gonna be harder because they don't have a time where they ovulate, or they don't have a time where they know they ovulate. So when people have hyperthyroidism, I remind myself that when you're in high school, and guys wouldn't know this, but girls, when they're excessively in sports, running, and they don't eat the best, they tend to have very irregular periods or none at all because they are so active and their body fat is very small. The smaller body fat a person has, the less chance of having a period. This is why obese kids, like little obese children, will have their periods sooner in life because body fat aids a period. You need to have body fat to have a period. So people that are hyperthyroidism, this is how you'll remember that they're amenorrhea. They don't get one. They have very high metabolisms, they're thin with not a lot of body fat, and they tend to lose their periods because they become, that metabolism speeds up to the point where they don't ovulate. So they tend to have very high chances of having infertility issues. They don't get pregnant. Okay, so what's the treatment? Does anyone know anybody with hyperthyroidism? Anybody? Does anyone know with hypothyroidism? I would say hypothyroidism is a little more common than hyper. I would agree with that. One of the reasons why we get hyperthyroidism is because of medications. I would say that's probably why. But hyperthyroidism tends to overstimulate your thyroid, and that's when you get like that goiter or that very high amount of nodules that are on the side of your thyroid. It's very obvious. So what they end up doing is they go in and do surgery on the thyroid. They can do medications first, but a lot of times these medications fix the problem for a while, and then they end up having to take the thyroid out. Why do people do not, or I shouldn't say people, but providers, why don't they just take it out and just give them levothyroxine to the rest of their life? Thinking about what the thyroid does, first of all, surgery is never the first option ever, unless it's like acute bleeding or something that's causing life-threatening issues. But we don't want to put this person into a state where we take out an endocrine gland. That is such a huge problem. And theoretically, yes, most people can take levothyroxine the rest of their life, but what if they are not good at taking meds, and then you don't have your thyroid working? Or what if they become sick for 6 days where they're vomiting for 6 straight days? They're not taking their meds. They can become more issues with their thyroid. So first, what we like to do, a lot of cases, is we like to give them radioactive iodine. I want you to think about that word for a second in your head. Radioactive iodine. And what does it mean to you? Radioactive. You can start singing radioactive. No. What does radioactive mean to you? Nice thing. I haven't had much cancer. You will next spring with Stacy. She teaches cancer. But radiation, radioactive activity is going to be something where it's very harmful to that tissue. It literally eats the tissue and kills it, and then that thyroid tissue becomes less secretion of that thyroid hormone. That's kind of how it's treated. Problem is, when they get this treatment, they can't be around children, pets, or people of child productive age because it could cause issues with that radiation. It's the same concept when you go get an x-ray done. They don't want to give you radiation in large amounts or a lot of times because it can cause destruction of the tissue. Now we're inserting radioactive material inside of your thyroid and killing it on purpose. Okay, we do a lot of weird things in medical, like where we put some stuff in your body that's like toxins and kill certain tissues in the body. So that is one area. So what is the point or purpose? To kill tissue of the thyroid so it does not secrete too much of the thyroid hormone. That's the goal. You have to be very careful though that this can take up to 6 to 8 weeks. So there's a potential, I think it's the first, I can't remember how many days, you don't know Stacy, but the first couple of weeks you can't be around children, childbearing age women, or pets because it can actually be harmful to those people. Okay? All right, some other medications that you might see. This is going to be your drug of choice for the test. I would know radioactive iodine, and that you have to be careful around pets and children, and that it actually kills the tissue of your thyroid. These other two, I just want you to kind of know what they're for. So you might have the question say, which of the following medications could treat hyperthyroidism? Okay, where you're looking for just, is it for that problem? Propylthiouracil, this one here, this medication is a medication that has to be very carefully given to cancer patients. Because what if the person has thyroid cancer and they get this medication, it causes something called a granulocytosis. Do you remember this from pharm? Granulocytosis. First of all, granulocytes, what are those? White blood cells. It causes low white counts. You have to be very careful because a lot of times people are getting these meds on top of a person that already has thyroid cancer and you're causing immunosuppression. So what are they at high risk for if they get some of these medications? Infection, right? So just be careful if they cause this issue, they could cause infection to that patient. But this is the one I'll probably ask the most questions on. You just might see this in passing. What is propranolol? Beta blocker. This makes sense why we give this, correct? Propranolol helps with heart rate and blood pressure. It's going to lower some of the side effects from that medication. Okay, here's your thyroid storm. I kind of put some of the interventions I've already talked about. I always get ahead of myself. But we want to cool this person down because they have the pyrexia, the very high temperatures here, and the tachycardia. We want to calm them down, but we've got to be careful not to calm or cool them down to the point of shivering. What does shivering do to your metabolic rate? It increases it. So I'm sure you guys have heard things about take a cold shower and it makes you cold and shiver and it makes your muscles contract, lose weight. You heard this? Okay, I've heard it. I've heard people say it. I think it's ridiculous. But the point is, when you shiver, that's your muscles contracting. It's like little workouts. Okay, it's essentially what it's doing. So when the person shivers, what would that technically do to a patient that has high thyroid hormone? Cause worsening state, right? We don't want them to shiver. It's a bad thing. Then mineral stimulation. A lot of times hyperthyroidism is found in Asian populations. It's very heavily tied to iodine intake. How do we get iodine? It's like salt or sodium, right? So what do a lot of Asian cultures enjoy for their meat source?
Shrimp.
Seafood, right? Seafood, shrimp, shellfish, things that have a lot of iodine inside of those, like authentic iodine, not just like I put salt in my food, like authentic iodine that comes from shellfish. If you go to a traditional Asian country, it's not like our Asian here, like that is American Chinese or American Vietnamese. Those are things where you have more sugar added and more things that are not like healthy. They focus on a lot of rice, shellfish, and vegetables, but they tend to have more iodine in their diet. Okay, thyroidectomy. Do you remember in the fall having some questions on this, on your ATI? I remember because people told me, they're like, you never talked about thyroid yet? I'm like, yeah, it's not here in the curriculum yet. Now I bet if you went back and took this ATI again, hopefully it's on the test today. I'm really hoping thyroidectomies are on there. Having this lecture is actually going to help you a lot for this med surge because endocrine is always the one where students struggle the most, and they ask a lot in this med surge one, so hopefully this will help you get a better score. But thyroidectomy probably will be on there, and if it's not, please let me know because I like to know what I need to teach. But thyroidectomies is when the person has hyperthyroidism. You're going to have overactive thyroid to the point where they might have to remove their thyroid. You would never have this done for hypothyroidism. It's always for hyper. Another case would be if they have cancer. The cancer is large amounts on the thyroid. They cannot treat it with medications. They need to have it removed. So once the thyroid is removed, where is the thyroid located? Right in front of your trachea. So if you pull a gland off of your trachea, what is the concern with almost all surgeries by manipulating or inflaming that area? Swelling, okay? So one of the biggest things after surgery is swelling. We have to make sure that swelling after is not occurring to the point where it occludes the airway. So in a person with hyperthyroidism, like it's a thyroidectomy, the number one nursing diagnosis is the airway, right? The airway, impaired gas exchange, whatever you want to say. Related to the swelling from the surgery. That's usually why it happens. So how do we get swelling to come down? I want you to think about if your toe or your ankle, whatever on your limbs is swollen. What do you do for it? Not necessarily ice, but like, what would you do probably to get, like, make the swelling come back so you can pee it out? Elevate it, right? So that's what we do for thyroid patients is we elevate the head of their bed so the swelling stays down. We do not want them to be supine in the bed, okay? A lot of times they'll have an occlusive dressing over their neck. It's kind of weird. They'll put like a bandage and they'll wrap it around. What is the concern we have of wrapping something around someone's neck? It could cause occlusion. So if you feel the patient is having issues with breathing, loosen up the bandage a little bit, but still remain heavy pressure on that thyroid because it could be bleeding too. Just making sure we look at those. Do we tell them to stay in bed for 2 days? No. We want them to get up and move around. We encourage deep breathing, coughing, but just be careful not to like make the dressing go flying, right? Like make sure the dressing's still there. And then we want to make sure they do not hyperextend or hyperflex the neck. What would that do? They just probably have some sutures, right? Or something that's closing it. So a lot of times if you've seen a thyroid scar, it's about, I would say it's about this big. And they literally open it up about that big. And so there's a high risk for bleeding, opening up that incision. We don't want to extend or hyperextend the neck. It's going to cause more issues. Why do I bring up parathyroid hormone? What does that have to do with anything? Remember back to patho what this even does? Where's the parathyroid located? It is on your thyroid. How many nodules of parathyroid exist? So if my thyroid looks like this, kind of looks like a butterfly almost. There's 4 little nodules, usually more on the posterior aspect of your thyroid. But these little nodules is what the parathyroid consists of. And these parathyroid hormone is going to be, when you take the whole thyroid out, you take the parathyroid with it. There's 2 things essentially that the parathyroid does. It regulates 2 electrolytes. Remember the 2? And they're inversely related. One's high, the other one will be low. Calcium and phosphorus. Good job. So, parathyroid hormone increases calcium in the blood. Where does parathyroid hormone take the calcium from? Bones. Yeah. So your bones store calcium. When you take a blood sample out of someone's vein, that is not their bone. So when you have high calcium inside of the blood, typically you have low calcium in the bones because it's taking it from the bones. That's how we get it. So high parathyroid hormone is going to result in high calcium. Low parathyroid hormone is going to result in low calcium because the parathyroid hormone that's getting stimulated is producing that calcium to be high in the blood. So no matter what your case is on your test, if you see a high phosphorus level, you have a low calcium level, and vice versa. So if it doesn't actually tell you, and it doesn't say anything about phosphorus, and it just says the person has high calcium in the blood, hypercalcemia, you're going to know that they're going to have low phosphorus. Okay, it's inversely related. All right, why don't you guys take a quick break, and I'll add a couple more things about the thyroid. Basically, you'll need a computer, but some people have a laptop, so it makes sense to switch. Everyone's using their laptop?
Yeah.
You want to switch with Abby just so she has a computer?
Right now?
He does, yeah, probably just not to switch this guy here. That what?
The Silverstein.
Silverstein?
The
Silverstein. Oh, Silverstein, it's Silverstein. When is it or what is it?
What is it?
You guys have never been to Service Day as juniors? Oh, that's required when you're, I think at your junior and senior level. But basically, the entire Dakota Wesleyan for the whole day, all the students on campus, or a lot of them, I should say, do some type of service in the Mitchell area. So some might go to like, I think one person's going to Emory to teach a school about some of science. But like around campus, they will clean it up, you know, replace some of the wood chips. They'll go to like Wesley Acres is where one of the groups are going. And they ask the residents in their independent living and like assisted living if they'd like anything for cleaning done. So most of the older ladies' houses aren't impeccably clean. They're like, can you get up on the fan and clean off the dust? Or will you wax my cupboards? Like it's just cute because it's like, okay, I'll wax these perfectly clean cupboards, it's fine. And then like we've had times where we clean the windows, like things that take about an hour and a half's time and then we leave. And then LB Williams from 3rd to 5th grade, that's another service area that you can do as a nurse, where you go over there and you teach stuff about health. So you'll have, the stuff is already ready for you, you just have to kind of show up and teach it. So I'm sure Penny will be sending out an email sometime in the next day or two about what those topics are, so the people that signed up can like prepare. But it's just kind of a thing they do, it's to give back, and like it's a day of giving, so that a lot of donors like donate money, and all the bigwig people like donate or match money to people that donate.
I just got it. I keep forgetting about it. Hmm? I'm sure you won't fail. I got an 80 the first time I scored up here. I didn't even, wasn't there a book or something you could read so I could-
All right, let's keep trucking along. The faster we get done, the more we can study. Okay, the only thing I really didn't talk about with the parathyroid gland was if the calcium is low, how will you know it, right? So I think thus far in nursing school, we've talked a lot of times about when calcium's low, what are the 2 signs we look for on assessment? But first, let's start with what is a normal calcium level, because we'll have to know for the test, like what is a range that we look for. 8 to 10, you might see some resources that say 9 to 11. What will I do to make sure it's obvious? I'll put it really low, but like a 6 or something. So somebody that has hypocalcemia, low calcium, these are things that before you even take a lab sample, you start to say, I think they might have low calcium levels. One of the first things you probably do as a nurse is not the Chauvet sign. Not too many people are like, let me do the Chauvet on you just to see, right? Not really. You take a blood pressure. And when you take that blood pressure, they involuntarily kind of contract their muscle, and it's not something they're doing on purpose. And it starts to curl up, and that is the Trousseau sign. If that ever happens to your patient where they involuntarily contract like that, the electrolytes should be monitored immediately because it could be very low. And a lot of times those are not going to happen unless it's severely low. If this was 7.4, you're not going to get a Trousseau sign. It's going to be like for 6, 5, something that's very low. And then how do we do the Chauvet sign? The cheek kind of like spasms a little bit. Other signs of low calcium levels is tremors. So if you notice, Trousseau's is kind of a sign of a tremor. It's like contracting the muscle. If you had high calcium levels, think of the opposite. Your muscles relax. So this is why, when you guys get to OB class, you're gonna give calcium gluconate for preterm labor. Why would we give calcium gluconate for preterm labor? You're relaxing the uterus, right? So it's relaxing the contracted uterus. So you're gonna find a lot of medical questions from our classes. Go to the fall, and you guys are like, oh, it's a lady, I must be stupid, it's uterus. No, it's still a muscle. It doesn't matter if it's a uterine contraction or a knee contraction, it's still muscle. So think about that when it comes to meds in the fall. Okay, last gland, yay, last gland, adrenal glands. This one is going to be obviously on top of your kidneys, but you're gonna have a different part of your anterior pituitary gland talking to your adrenal glands. What was the way I said to memorize it? A and A, right? A and A. So they're located on top of your kidneys. For this test, you have to know the two parts of the adrenal gland because there's different hormones that come out of these glands. So let's start with the outside border. What is this called? The cortex. Cortex. Okay. What is the middle part called? Medulla. Guess how I memorize it? Medulla is middle. I don't know. Whatever works for your heart. Okay. You gotta just do what makes sense. I made the dumbest stuff in college that was inappropriate, but it worked. I still think about it. Just can't share with you today. But things that are going to be silly is going to make it more knowledgeable in your brain. So in the cortex, there's three things. And in the medulla, there's two things. Okay, so let's see if we can remember. Sex, salt, and sugar. Remember we talked about that in patho? Okay, so I'm going to put the first one, salt, sugar, and sex, because I think in that order, that would kill you the least at the end. Probably what I'd say. Salt would kill you first. Yeah, I'm going to go salt, sugar, sex, because blood pressure probably tank. Sorry, going from life-threatening to not life-threatening. So what is your salt hormone? It's just not salt. It's not sodium. It stimulates sodium. Aldosterone. So aldosterone in your body, what is the goal of it? So if your adrenal cortex secretes aldosterone, what is the point of it? Why would it matter? To retain fluid, to have a blood pressure. So if you don't secrete this, your blood pressure goes down to the point of not having one, and you die. So is it life-threatening? Yes, you need aldosterone. Sugar. Cortisol. What does cortisol do? There's one main thing that it helps with sugar. Raises blood sugar. Do you remember the counter-regulatory hormones for diabetes? One of them is cortisol, and it helps raise blood sugar. So if you have no glucagon in your body, cortisol is going to help. When does cortisol get secreted? There's two times. Stress. So like I'm running from a bear, your cortisols are high in the middle of the night. Why would your cortisol raise in the middle of the night? It's been 10 hours since you ate supper, your blood sugar is going down, cortisol says, let's go blood sugar, and raises it. All right, sex. I'm going to put androgens here because it could refer to your estrogens or your testosterones. I understand that female male characteristics are something that you have to have for fertility, ovulation. I get that. Is it going to kill you? Probably not. It can cause side effects, but if you have at least some functioning of this, you're not going to die. Okay? I'm not saying that the person's not happy because they'd probably be very upset if they have different characteristics. Okay? But this one we tend to not ask so much in this class. I want you to know that this is the third option. There are no questions on the test on it. Okay? But I want you to know the third one is androgens, estrogens, testosterones. Okay? That's just what it secretes. And then the medulla, what is secreted in there? They're considered catecholamines. They help your blood pressure increase. Remember? Starts with E, epinephrine, and norepinephrine. Okay? So epinephrine is what you feel like on test day when your heart's racing, you're sweaty, you're anxious and nervous. Epinephrine's being released. Epinephrine and norepinephrine also are released when your body is stressed from blood loss or you lose blood. Your body goes, okay, the fluid is leaking. I need to make my heart pump harder to maybe help with some of the problem. So this is in itself, if it's stimulated, stimulate these two things, it's gonna cause blood pressure and heart rate to increase. Okay, so there was your cortex. It's a negative feedback system. Remember, all of our pituitary gland and endocrine functioning works on this negative feedback. So let's say a person has, we're just gonna bring up Cushing's disease because we're gonna talk about that. So Cushing's disease tends to have a high amount of these hormones, specifically cortisol. So they tend to have very high blood sugars. What would you anticipate in Cushing's disease is happening with that ACTH? So this is high, the ACTH is trying to be low. It's an inverse relationship. They're trying to lower it by doing that mechanism. If you have Addison's disease, it's the opposite. Addison's and Cushing's are opposite conditions of the adrenal gland. So Addison's disease has low amount of this cortisol. So the ACTH would be high. This is why they always run both, because they want to see, is it Addison's or Cushing's, and that's how they diagnose it. They literally look at those two levels, and they start there, and they see if you have the problem that exists. Okay? All right, medulla. There's cells that are inside of this medulla. They're called pheochromocytes. There was a problem that I talked about in patho that can cause this issue that would cause your blood pressure to be severely high. It has nothing to do with what meds they're on, has nothing to do with like the antidiuretic hormone, and their blood pressure, maybe at the age of like 20, is like 250 over 120. It's not because they're obese, cardiovascular disease, like nothing like that. Why would their blood pressure be that high? And it has something to do with your pheochromocytes inside of your adrenal medulla. I gave you an episode of House. Remember, you guys don't watch House, you guys are too young. There was an episode, and there was a guy, and I remember I was like, he's got pheochromocytoma. It's a tumor of your adrenal medulla, where this tumor comes in, puts pressure on the adrenal medulla, causes excessive epinephrine release to the point where they're hypertensive. So when somebody has pheochromocytoma, that is a tumor of those pheochromocytes, and it causes your blood pressure to be excessively high. So let's just say the next time you get a blood pressure and it's really high, should you think this first? Yeah. This is like, we've looked at everything else, maybe it's this, okay? Is it common? No. It's just something to be aware of, that if you go back to your pathophys of what the adrenal medulla does, you got your answer, okay? So what I will encourage you to do is on your test, I'll say the person's adrenal medulla, the person's adrenal cortex, you're going to eliminate hormones or add to your final saying based on which hormones are released from where. So this is why I said for this test, just know the pathophys, you're halfway there. And honestly, maybe 75% there. There's little clues in the stem of the question based on what you read. This is why I say don't read too quickly. You might have just saw adrenal gland, but it said adrenal cortex, okay, or adrenal medulla. So if I say the person has stimulation of their adrenal medulla, do not put cortisol, do not put aldosterone, do not put androgens, that's the cortex, okay? So just kind of read the question to see what it's asking you. Okay, we've seen this little boy before in patho, hold him back on. Okay, that was him on the left, and then he got a syndrome called Cushing syndrome. And I want you just to tell me what you see for differences in characteristics. Moon phase, he gained weight obviously, adipose tissue. If we turn him around, we might see something on his neck, like the buffalo hump on his neck, okay? They tend to gain weight in this adipose tissue or have truncal obesity because of this excessive cortisol. Cortisol is sugar, right? So it's gonna cause that excessive weight gain. This is why when people are on corticosteroids long term, it stimulates a very close related to Cushing syndrome. Cushing syndrome is too much cortisol in the body. What are corticosteroids? Synthetic cortisol. That's essentially what it is. Corticosteroids are synthetic cortisol, and if you get steroids for long periods of time, you're gonna have very similar symptoms or side effects. Okay? So these people have high blood sugars. Do you remember when side effects of corticosteroids? These are the same answers. Why do they have high sodium? High high aldosterone, okay? So their aldosterone is increased. And if you have high sodium, what comes with it? Here comes water. So they're gonna have fluid retention, high blood pressure. It's gonna cause it to increase. That's where the hypertension comes in. And then in most cases, other than dehydration, most of the time your sodium levels for endocrine will be high, your potassium will be low. Okay? So what kind of foods would we encourage for Cushing's disease? High potassium foods, we probably limit the sodium and fluids, and then be cautious of like carbohydrates for sugar. Okay, they can have their adrenal gland taken out in very severe cases. I've never heard of someone taking their adrenal gland out unless there was a horrible tumor cancer there that they couldn't get out. They can also go to their pituitary gland. People do have their pituitary gland removed. It's called a transsphenoidal hypophysectomy, right here. How do they get it out? This is this surgery. They do not just go to the top of the brain right here, because where is your pituitary gland? If you feel the soft palate of your mouth, don't put your tongue there. The soft palate, not hard. It's literally like this far above it. Probably like a centimeter. Okay? So if you puncture your soft palate of your mouth, what are you problematically going to do? Hurt your pituitary gland. It's like right there. So what they do is they go up through the soft palate of the mouth, and they go up just like a tiny bit. They make an incision, and they take that out if that is the tumor problem. But if you take out an entire pituitary gland, what's the problem? All those hormones. You do not want to have your pituitary gland taken out. You will have lots of issues and be on a ton of medications. So this is end result, but what do you think is a high risk for that surgery? Putting your incision into the roof of your mouth, access to your brain within a centimeter. What if your cerebrospinal fluid leaks, right? Or infection gets in. Think about your mouth. It's not very clean, right? We eat stuff off the floor. Well, maybe you don't, but that 5-second rule, right? So if you think about putting things into your mouth, infection, think about like just an upper respiratory infection in the back of your mouth. If that gets up into your brain, it could cause encephalitis. So the biggest thing with the transsphenoidal hypophysectomy, you're gonna get this quite a bit. If it is on a test, it's gonna ask this. Is cerebral spinal fluid leaking because they didn't adequately close it? And if you have leaking of cerebral spinal fluid, what does it look like? It's clear. What else is clear that comes out of your mouth or your nose? Snot. How do we test to make sure it's not snot? So let's say I have dripping of my nose and it's coming down, it's like coming down from that area. If I put it on a piece of paper, not necessarily this, but like tissue that's white, it will dry with like a yellow ring around it. You'll see yellow like halos around your snot. It'll like be clear, the yellow halo. They can also test it for glucose. If there's glucose in there, it tends to be highly suggestive of cerebral spinal fluid. Okay? You do not want cerebral spinal fluid leaking out of your brain. That's not a good thing. So something we look for complications.
So for the post-op period, is just make sure not.
Yep, make sure it's closed and they're not leaking cerebral spinal fluid, and you're monitoring for infection. Because what if they got a fever within 24 hours after having this done? They have to do a whole workup to make sure that they don't have encephalitis. It could happen. But I bet if you typed in on Google, transsphenoidal hypophysectomy NCLEX questions, that question's on there, with like cerebral spinal fluid leaking. That's what they like. But it deals with where the hole is. People always think here is where they have the surgery. It's in the mouth, underneath that soft palate. That's where it is. I hear the ringing. Do you guys hear a ring? Mm-hmm. Like a alarm outside or something?
Mm-hmm.
Quit it. Dang it, you're gonna make me start thinking I have problems. Okay, did you guys hear my problem? I gotta tell you this story. You know when we went to well, some of you went to Huron. The hearing screening, they do different hertz. So I was in my house and I was like preparing for that clinical, and I was like looking at the different hertz, and I'm like, what can I hear at? So little kids, they assess them at 1,000, 2,000, and 4,000 hertz. 4,000 is still pretty loud, but I was going to 5,000, 6,000. I got to 7,000 at home, and I'm like on YouTube, like listening to it on YouTube, and it was 8,000, and my husband's like, what the hell are you doing? And I was like, what are you talking about? And I like had the volume up, I thought it wasn't working. And he's like, you can't hear that sound? No. He's like, you're joking. It is like obnoxious screeching, like really, really loud. And I'm like, oh my God, my hearing, like what's wrong with my hearing? So I sent a Snapchat to like 10 of my favorite friends, and I'm like, listen to this video, do you hear anything? Every one of the 10 was like, you can't? We're gonna listen to it after, like, when we get done this lecture. But it seriously was like alarming that I couldn't hear it, and then like I went to like 9,000, 10,000, all the way up to 16,000 hertz, which should be like a dog can hear, essentially. And my husband was like, yep, I can hear that, yep, I can hear that. And like, I even tested on my kids. I was like, just gonna play it and just see what their reaction was. And my daughter went like this on her ear, because it was so bad. And then I'm like, maybe I have hearing issues. But I was like, what in my life has caused this? I went to a hairball concert like 3 years ago with Stacy. And I went up to like, I was on the side like listening, like, but I was right next to a speaker. And the next 2 days, I could not hear for 2 straight days. And my ears were like not bleeding, but I remember going home like, I'm in pain, like I cannot hear. And I still think it's hairball. Hairball caused my hearing loss. So from then on, I wore whatever they call them, earbuds. For the next 2 times we went to hairball, and I'm like, this sucks. Like going to hairball and you can't like, you can hear it, but you can't really hear it. So I was like, I'd rather just not go. But seriously, do not go to concerts without, like, don't hug the speakers and don't do that to your hearing. Because I'm pretty sure I'm going to be the deaf person when I'm like 65. Life lessons, kids. Don't do what Megan does. All right, we're almost there, guys. 2 slides. Actually, the last 2 are questions. This is the last slide. So, last thing that can go wrong with your adrenal gland. So, Cushing's disease, everything is stimulated. Addison's disease, it's the opposite. So if you have a person that has low aldosterone, low cortisol, low androgens, think about the symptoms they'd have. Low blood sugars, right? Because they're not having that stimulation of cortisol. Low salt. Do you remember my little tip about everyone is supposed to have no salt except Addison's disease? That's the one condition where you can say have as much salt as you want because they are deficient and they run low with their sodium levels. It has to do with the low amount of aldosterone inside of their body and they do not make that sodium. So how would you feel if you had low sodium levels, therefore not retaining fluid? You're going to feel weak and fatigued. And they tend to have very thin appearances because they're not retaining that fluid. Their blood sugars tend to run lower. So what do you suspect is the treatment? You give them steroids for the rest of their life. That's what they get. Which makes sense because we're giving them kind of like the synthetic cortisol. They might have to take salt tablets. Have you guys had patients yet that had to take salt tablets? They literally get like a tablet of salt. That is one you would not want to crush. It'd be like eating a tablespoon of salt just plain. It doesn't taste good. So they like eat it really fast so that it's not in their mouth. Okay?
Do they both get prednisone for that?
Not necessarily prednisone, but some type of corticosteroid, yes.
They both do, Cushing's and
No, not Cushing's. Cushing, they make too much cortisol, so we would not want steroids for them.
So what kind of, like, for treatment, you use that medication, so don't.
Right, so with this person with Cushing's, it depends on what their treatment or their symptoms are. So let's say they're having hyperglycemia, they might have to be put on insulin or oral diabetics. So there's so much is, you have to treat why they're having this excessive amount of cortisol. Whether it's take your adrenal gland out, take the pituitary gland out, which are excessive, but most of the time medications can be what they do for an indefinite amount of time. You don't want to start with surgery first, that's and don't tell. But for the most part on your test, I'm not going to ask you specific questions on meds, more about just kind of like, if it's bad enough, they might have to have surgery. One last thing, potassium, because I want to make sure you understood that with Addison's disease, they have that low salt or that low sodium relating to low aldosterone, and that inverse relationship with potassium. So these people, we don't want a lot of potassium. Okay, so they can have all the salt they want, but they can't have potassium. Because potassium is going to make it further with that problem. So potassium foods are not their friend. I had a student, I couldn't even tell you who it was, but a couple of years ago, she's like, my aunt has Addison's disease, and she literally cannot have potassium because her potassium is so high. Like that was one of the diet things she needed to have, was low potassium foods. So they have to be very careful of that. Okay, let's see if you remember a question. Okay, 24-year-old mother visits her obstetrician's office 1 week after delivering her baby. She's having trouble with breastfeeding and milk expression. The obstetrician prescribes a nasal spray that will stimulate the posterior pituitary gland to release which of the following hormones? Okay, so knowing what you know, let's just say you know the pathophys. Would this have helped you in this question? Posterior pituitary gland. We're down to antidiuretic hormone and oxytocin. So if those two are on there, only one is on it. You didn't even have to know what oxytocin does. You had to memorize what hormone was secreted from where. Okay, so pathophys is good for this test. Make sure you know where they're coming from. Here's another one. As the young mother is walking to her car, she becomes aware that someone is following her. Her body responds with a fight or flight response, which is regulated by the adrenal medulla's secretion of what? So adrenal medulla. See how you have to read? Do not do this to yourself in the test. You will hate yourself. Like literally, you'll be like, I knew the answer, but I thought it said cortisol, or I thought it said cortex. Medulla and cortex have different hormones. I promise you, it's on the test. Read the question. Okay? So the other three are your cortex. What would be another hint here? They're all three on there. If those are all the cortex, you can't choose between one. They all secreted from that hormone. So you could, by process elimination, do catecholamines, which are epi and norepinephrine. Okay, let's listen to the hertz.